Built to be lonely, to love the absent. Find me, free me from this corrosive doubt, futile despair, horror in repose. Sarah Kane was an award-winning British playwright who unfortunately went on to commit suicide. She was one of many people who woke up and will continue to wake up every morning feeling lonely, hopeless, guilty, anxious, unable to sleep, unable to eat, and contemplating suicide almost every day. It's a dark way to start off a presentation, but it's also the dark reality of patients who suffer with major depressive disorder. My project this summer was a little different. Instead of analyzing mass loads of data or perhaps working with test tubes in a lab, I was given the opportunity to understand and really get inside the specific case of a patient who has dealt with depression her whole life. And then I was tasked with researching the existing literature to see if there was any evidence to support the way in which she was treated. What my research ultimately boiled down to was answering this question: how can certain medications alter the efficacy of electroconvulsive therapy, a treatment for depression? But before we get into the treatment, I'd like to tell you a little bit about the case. So I'm going to refer to the patient as Mrs. A. Mrs. A is a 59-year-old divorced mother of 2 children. Throughout her childhood, Mrs. A unfortunately experienced many significant traumas in her life. On top of experiencing severe anxiety, she had some unfortunate instances with sexual abuse. She witnessed a murder, and she had to deal with the deaths of many loved ones. Mrs. A went on to get married, but after her first child, she began to struggle with postpartum depression, and it was around this time that she began to struggle with cocaine and alcohol abuse. Mrs. A went to go see a community psychiatrist who treated her for bipolar disorder and borderline personality disorder. Unfortunately, most of the medications that she was prescribed had very limited therapeutic effect, and as a result, she attempted suicide on more than one occasion. It was only after Mrs. A's partner committed suicide and blamed her in his parting note that her condition became much worse. She was admitted to inpatient care, and that's where she received her first course of electroconvulsive therapy. Unfortunately, just like the medications, ECT was not as effective as we would have liked. She was then referred to a second psychiatric institution, a teaching facility. Her medications were revised, and she was consulted for treatment-resistant depression, and she was given another course of ECT. And I'm happy to report that just 3 weeks ago today, Mrs. A celebrated her 60th birthday, feeling as happy, as motivated, and as symptom-free as she's ever felt in her whole life. So, ECT, what is it? Well, simply put, electroconvulsive therapy is one of the most efficacious treatments for depression that we have today. Now, what happens is that there are 2 electrodes placed on either side of the patient's head, and an electric shock is administered throughout the brain. And what this does is this initiates a seizure in the patient. Now, this seizure is vital for the therapeutic effect of ECT. How and why that's the case, we're not entirely sure. Okay, there's still a lot of research being done trying to understand the exact mechanism by which ECT elicits its therapeutic response. But what we do know is that it works, and it works well. Reports have surfaced saying that almost 75% of patients who receive ECT enter remission, and that's a remarkable statistic because ECT is only delivered and reserved for those patients who don't respond to antidepressant medications in the first place. Now, in terms of side effects, other than the usual side effects that patients can expect from being under general anesthesia, the only main side effect is retrograde amnesia. That does get better with time. So, back to the problem. The first course of ECT didn't work. The second one did. So what changed? Well, the only thing that changed, other than a change in the psychotherapy that she was receiving from her psychiatrists, was the medications that she was on. Now, these are the 8 medications that Mrs. A was on prior to starting the first course of ECT. Before continuing with the second course, 3 of them were discontinued. And these 3 medications are what were directly responsible for the change in efficacy of the treatment. Now, I don't have time to talk about all 3 of them, but 2 of them, clonazepam and flurazepam, fall into a category of medications called benzodiazepines. Now, benzodiazepines are normally administered for three main purposes. First and foremost, they are anti-anxiety medications. Now, anxiety has been found to be highly comorbid with depression, and so it's not uncommon for psychiatrists to prescribe benzodiazepines for those struggling with depression. Now, the third effect, which is what we're really concerned about, is that they are anticonvulsants. Now, I'm going to throw something out there. You guys tell me what you think. If the point of ECT is to elicit a seizure or a convulsion, then maybe it's not such a good idea for the patient to be administered an anticonvulsant. So, what effects do benzodiazepines have on seizures? Well, what research has shown is that benzodiazepines actually decrease the duration of the seizure that patients experience during ECT. Now, recent findings have shown that perhaps there's a correlation between seizure duration and the efficacy of the treatment. So, if the seizures are getting shorter, the treatment thereby isn't as effective. But this link and this correlation has been questioned recently, all right? Researchers have begun to think that perhaps seizure duration isn't as good an indicator as we originally thought for efficacy of the treatment. And so that has brought about conversations into a new subject called seizure threshold. Now, seizure threshold is the minimum amount of electrical activity in the brain that needs to be surpassed in order for a seizure to be achieved. Now, what research has shown is that seizure threshold is actually increased and raised by benzodiazepines. So, seizure threshold is increasing. That makes it harder for us to surpass that level and achieve those seizures. And that mechanism is what's then responsible for the decrease in seizure duration and for the lack of seizure adequacy. So, we know what it happens. We know what benzodiazepines do, but how do they do it? How do they do it on a cellular and a molecular level? Well, benzodiazepines have been commonly known, and research has shown that they potentiate the activity of GABA, the primary inhibitory neurotransmitter in the brain. Now, what benzodiazepines and GABA do is they increase the influx of chloride ions into cells. Now, chloride ions are negative. More negative ions coming into the cell decreases the membrane potential, and that makes it harder for those action potentials to fire in the body. Now, that's what's responsible for the sedative effects of benzodiazepines. But what we're really concerned about are the anticonvulsant effects. Now, GABA plays an important role in stopping the transition from one convulsion in the body turning into what is known as status epilepticus, or a fully blown seizure. Now, benzodiazepines enhance the GABA activity, and so they therefore enhance the anticonvulsant effects of GABA. So, we know what happens. We know how it happens. Now the question is, does it actually happen? We've observed this mechanism and this phenomenon in one case, in the case of Mrs. A, but has that been observed in studies all across the world? And the answer is yes. Now, this study evaluated patients with their treatment on ECT. And what it shows in this simplified table here is that a far less proportion of patients respond well to ECT when they are under the influence of benzodiazepines compared to those patients who receive ECT not under the influence of benzodiazepines. Now, that's 67% compared to 86%. That top row there, that is a considerable margin. So what does this all mean for us? Well, we prescribe medications oftentimes for one intended purpose. Now, these medications often have three other effects that we don't even know about. Now, it's our job to make sure that we're monitoring these effects so that we can optimize treatments not just for playwrights, but for students, for athletes, for politicians, for me, and for you.